Start, ma'am.
Okay. So we are online now, is it?
Yes, ma'am.
Okay. A very good evening to everyone, and a good day, rather, I should say, depending on which part of the world you're watching from. A big welcome to you from Dr. Agarwal's Eye Hospital and the Dr. Agarwal's Grand Rounds. And as part of our educational objectives, we are really happy to be hosting here Dr. Jack Parker, who is from Alabama and who is a very renowned corneal surgeon who is the owner of Parker Cornea in Alabama. He's considered one of the world's foremost authorities on keratoconus and Fuchs dystrophy. He underwent his training at NEOS, which of course we all know is where DMEC was born. And he's probably the only US eye surgeon who's been trained at NEOS. So he's also part of the board of directors of NEOS USA, and he has been doing fantastic work. He's right there at the cutting edge of technology, keratoconus, Fuchs, and he is a prolific publisher of papers. You go on PubMed and search with Jack Parker and you see this huge list of papers coming up. So Jack's name is everywhere. Of course, even on talks, seminars, webinars, and everything. So Jack, we're really happy to have you here. And most of all, because Jack, the latest qualification he's just added to his wide repertoire is the best one, I would say, that of being a dad. Jack has just had a baby girl yesterday, and we're really happy for you, Jack. Congratulations. And thank you so much for still, despite all your new responsibilities, making it to this webinar here.
Well, what a sweet introduction. Thank you so much, Susan. You know, the greatest fortune of my life really has been to associate with so many wonderful people, you know, I mean, just genius, world-changing heroes of mine. And of course, among that list, I include you, you know, and so I'm so glad to be able to give a talk here in which I tell people more about sort of your innovations and your brilliant insights. And you're right, the newest brilliant association that I have is with my new daughter, who was born just 12 hours ago. And so I'm unshowered and unshaven. And so thank you all for letting me present to you in this condition. I'm also sleep deprived, but hopefully something that I say will make a little bit of sense. So then, Susan, with your permission, I guess I'll just go on and share.
Jack, I'll just make a very quick introduction of the rest of the panel, if you don't mind. We also have with us Dr.SUJATHA MOHAN, who is a very well-known phaco-refractive surgeon who specializes in external eye and diseases and cornea, and is the medical director of Rajan Eye Care, which is one of the foremost centers in Chennai and in India and the world, known very well for her knowledge and her skills in cornea and refractive. And she's also a very prolific speaker, participating in so many courses, international courses, being invited guest for so many international courses. So it's an honor to have you here, ma'am. She also runs the eye bank, the Rotary Eye Bank. And also the one thing that I really find great about Sujatha ma'am is that she and her husband, Dr. Mohan Rajan, they do so much of charitable work. And, you know, it's throughout this pandemic, they've been so at it, you know, donating to hospitals, doing so much of donation. So that is really something. Hats off, Sujatha ma'am. Welcome here again. We also have as the second panelist, Professor Lionel Raj, who is the regional head clinical services of our Agarwal's branch at Tirunelveli. And Lionel, again, requires no introduction. He is, in one way, fantastic. In one word, fantastic. That's the word I would choose for him. He, be it clinics, be it surgery, be it the business aspect of ophthalmology, be it research, be it conducting trials, you name it, and Lionel is there. Be it sports, tennis, Lionel is there. His day is not 24 hours. I think for all of us it's 24, but Lionel has a 48-hour day somehow squeezed into a 24-hour. So Lionel, welcome here, and thanks for being here with us.
Thank you.
We have Moses, who's part of our Kanchipuram Eye Branch. And Moses, thank you so much for being here. He's been with us for many years now. He did his fellowship here with us. That is great, Moses, training here with us. Thank you so much for being here. He takes care again of cornea. So we've got a lot of cornea specialists here with us. Rakesh, again, a very, very bright and upcoming ophthalmologist who's taking care of the entire clinical board education. Thanks for being here. Kala, are you there? We have Dr. Kala Devi Satish also. There she is, who is the head of all the medical director of many of the services in Agarwal's, and also runs many of the branches in Agarwal's. So she's a really busy woman who's always, you know, organizing things and taking care of so many things Agarwal. Thanks, Kala, for being here. And with that introduction, I think we'll start off with your talk without much delay, Jack. Thanks so much.
Great. Okay, let's see if we can share a screen here. Okay. All right. Well, guys, I hope this is all coming through now. And it really is such a privilege to be here with you. And so thank you very much for accepting me. And we'll just talk a little bit about things that are hopefully useful. This is the new addition to the family, baby Iris, and my wife, Christina, holding her. And that has been an exciting past few hours for us, for the Parker family. Now, to talk about keratoconus. Just to briefly review the subject matter of the talk, before we even get into sort of the surgical remedies, it's important to set us a few things straight. So the first thing is the dictionary definition of keratoconus. The textbook definition is that keratoconus is defined as a bilateral condition, a bilateral disease of progressive, non-inflammatory corneal steepening and thinning. And when I first heard that definition, it more or less just passed unfiltered through my mind, but it is actually relevant in a number of regards. Well, the first reason is that you see often patients who are considered with unilateral keratoconus, and I would caution you to be suspicious of that diagnosis because almost invariably you will see a highly asymmetrical but still bilateral disease, according to the textbook. And the next thing is this idea of keratoconus being non-inflammatory is also relevant. This is a patient who was referred to my clinic less than a month ago by his referring optometrist. The diagnosis was progressive corneal steepening and thinning, worse in the right eye than the left, which was topographically confirmed. But this was not a case of keratoconus. And the way you know it's not is you can see how inflamed these eyes are. And inferiorly in the right eye, you can see this ischemic area of whitening or necrosis. It's almost like this person had a trabeculectomy performed inferiorly. This was necrotizing scleritis in a patient with no previous medical history. Necrotizing scleritis is a life-threatening disease, of course, certainly vision-threatening, you can see. And of course, the differentiating distinction is that keratoconus is not inflammatory. There are other things which can look like keratoconus on our imaging, and by history, there's pellucid marginal degeneration, which is similar. It is distinguished by having a worse prognosis than typical keratoconus because the steepening and thinning are not coincident. It turns out that the steepening is central or paracentral inferior, and the thinning is far peripheral. And as a result, these patients are more difficult to transplant because there's less to sew into. Post-LASIK ectasia can look very similar to keratoconus, but the history is different. Often there is an interval period after the LASIK of, say, 10 years or so, where the eye is fine and the vision is good. And then 10 years later, people suspect, oh, maybe there's some myopic regression, but you better be careful because that is also characteristic for post-LASIK ectasia 10 years later for the cornea to destabilize. If you want to ask or answer the question, what causes keratoconus? There is a simple answer and a complicated answer. The complicated answer is that we don't know, and it probably has something to do with genetics. And the simple answer is eye rubbing. If you ask patients if they rub their eyes and they're keratoconic, overwhelmingly the answer is yes, they will admit to it. Or if they say no, their partner will say yes, they do it. Interestingly, I was having a conversation with a representative from this company, Zemer, and I was discussing with her why the incidence of keratoconus, at least in the States, seems to be lower in women than in men. And she says, oh, yes, that makes sense to me. And I asked her why, and she says, well, young women wear eye makeup, and they don't want to smear their eye makeup, so they don't rub their eyes. And I thought, what? That actually is probably true. That makes some sense to me. But anyway, we work very closely in Alabama in our clinic with our local allergists. We refer them patients to get their allergies under control, and they refer us patients who they are suspicious may have some eye disease because they present to the allergy clinic and are rubbing their eyes. Now, if you read the textbook about how keratoconus is diagnosed, I would advise you not to believe what you read in this regard. And the reason is that the textbook pictures of keratoconus look like this: horribly advanced disease. Keratoconus where the cone is so bad, it's literally distorting the shape of the patient's face. That's the Munson sign. And the reason you don't trust the textbook here is that you want to diagnose keratoconus way, way before it looks like this. It's kind of like bullseye maculopathy. You don't ever want to diagnose plaquenil toxicity through a bullseye lesion in the macula. That's late stage disease. And all of these presentations, these are late stage disease. So this is not useful to you, the astute clinical diagnostician. You want to find keratoconus before it looks like this. And so what you should do is trust your gut. If you see a young person with 3-4 diopters of cylinder, that should raise your eyebrow, particularly if they've been changing their glasses recently. Maybe if they've had LASIK in the past and they've got 2 or 3 diopters of cylinder, that's not normal. If they tell you there's something in their family, their mom had an eye problem, that should raise additional suspicions. And another trick that we use is looking for the scissor reflex on retinoscopy. You know, we are fortunate to have lots of sophisticated imaging technology, but it is incredible that with the dilated eye exam, with streak retinoscopy, you can see this optical abnormality in the cornea, this opening, shutting, snapping scissor reflex. And this somehow helps me subjectively just to make sense of what's going on in the cornea of the patient. So sometimes if you have an equivocal pentacam or you're not sure what the topography is telling you, I recommend you just try this. Dilate the patient and just for yourself assess the optical performance of the cornea. Just look and see what it's doing to light. And that is somehow so clarifying for me. Now, if you have a topographer, particularly if you have one of these nice pentacams, it makes your job all the more easy. You just look for inferior steepening of the cornea, coincident with some thinning. Now, the standard of care for patients with keratoconus is corneal cross-linking, and all patients with progressive disease should be cross-linked. That's the international consensus global recommendation that if you have keratoconus and the disease is progressing, it doesn't matter what your vision is, it doesn't matter what your age is, progressive disease should be cross-linked. The analogy that I like to provide is it's kind of like the definition of clinically significant macular edema. You know, patients receive intravitreal injections of anti-VEGF to deswell the macula, and the criteria for these injections are CSME, clinically significant macular edema, not the patient's vision or subjective complaints, because we know that if you allow the macula to remain swollen, even if the vision is good, 20/20, 20/25, the patients will develop long-term structural changes which are not to their benefit. And it's the same way with keratoconus. If you have an ongoing disease, it gets treated even if the patient is subjectively happy. As you all already know, cross-linking involves debriding the corneal epithelium, dripping riboflavin solution over the surface of the cornea, and applying this UV radiation. Here is a little video which shows the procedure. We use a little blunt instrument just to debride the epithelium and then drip this riboflavin solution over the surface of the cornea. And then the patient, while they're still receiving riboflavin drops, look up at this light, and that cross-links them. So it's a procedure which is painless, it's uneventful. About half of our patients fall asleep during the procedure, which we do in the clinic in Birmingham, Alabama. Cross-linking can be done a second time if necessary, but the success rate is greater than 98% for patients who have mild to moderate disease at arresting the progression of their disease. It used to be the case that I thought that patients with very, very steep or very, very thin corneas were not candidates for corneal cross-linking. So I used to think that if you had a Kmax of 70 or even 80 and a thinnest point thickness of 300 microns, you couldn't be cross-linked. I've changed my mind recently, largely as a result of Dr. Jacobs, of Susan Jacobs, and her publications of contact lens assisted cross-linking. Now we're able to cross-link even very, very thin corneas. That is advantageous because even a very advanced cone often can achieve satisfactory vision with a scleral contact lens. And so our patients with advanced keratoconus, we really do like to cross-link them to stabilize the course of their disease, even if they're already quite advanced. There was a study published just a month ago which showed the impact of delaying cross-linking. This was performed on patients in Italy whose cross-linking was delayed by 3 months because of COVID. And what this study found was that in 3 months delay, 70% of patients progressed, and the consequence of that progression was one loss of vision on the Snellen eye chart. So 3 months' time is enough to permanently cost patients one line of vision. So progressive disease should be treated aggressively. When you're cross-linking patients, when they have these special masks on, it can produce quite an interesting appearance, but ordinarily it's not a very dangerous or involved process. The complications you have to look for are all the complications associated with removing 9 millimeters of central corneal epithelium, which is to say potential for infection, potential for delayed reepithelialization. If you're cross-linking somebody who has post-LASIK ectasia, there are reports of DLK. And so you have to be a little careful that patients would not have a DLK and treat them appropriately if they do. The problem with cross-linking is it doesn't improve patients' vision. The analogy that I make is that if your house is on fire, you call the fire department and they put the fire out, but they don't rebuild the house. So cross-linking, unfortunately, doesn't restore any of the damage that has already been done. There are some therapies for that. One, of course, is PK. PK is an option that has the ability to significantly improve patients' vision, but it comes at the significant risk, which is to say lifelong responsibility to manage sutures and drops for rejection. You have to worry about significant unstable or irregular astigmatism. There's a possibility of wound dehiscence, glaucoma. There are lots of problems with PK, and so there has been an impetus to find a safer alternative. DALK, of course, may be much better in one regard than PK. By not transplanting the endothelium, the risk of graft rejection is much lower, so the patients don't have to use steroids as intensely or for as long. But many of the other complications of PK still remain. You still have these large incisions, you still have sutures, the eye is still weak, you still have to worry about the refractive surface of the eye. As an alternative to DALK and PK, for patients who have moderate disease, Intacs can be implanted. And Intacs are nice because they minimally reshape the recipient cornea. That can allow contact lenses to fit better and to improve the optics of the cornea. There's a little video here, which we'll show here, that demonstrates the Intacs technique. The surface of the cornea is sort of marked for centration. Then you can use a diamond blade to create an incision in the cornea. And here I'm showing a manual technique, which I prefer over femtosecond laser, mostly because we don't have the femtosecond laser where I practice, but also because this is just very simple. You use a blunt corkscrew blade to dissect a channel in the cornea, and then you slip the Intac segment in, okay? So here's pushing the Intac segment into final position. And the whole surgery really just takes 4 or 5 minutes. And if you want to put a stitch in the cornea at the end, you can. Here's a typical result that shows a patient who's had Intacs. The A is the pre, and the B is the post-op, and C is the difference. And this patient had 7 diopters of corneal flattening after Intacs combined with cross-linking, which is a good result. But there's an even better technique besides Intacs, and we've been doing more and more of this. For a year, we couldn't perform this in the States because of insurance prohibitions. But now we've started doing more and more. Susan, now we're starting to do one a week again, which is kind of nice. We did one again last week. Intacs and CARES are similar in that you flatten the cornea with the implantation of some new material. But CARES is better than Intacs because rather than using a piece of plastic, you use a piece of cornea. And this piece of cornea is implanted in the same manner and in the same location, but it achieves a much greater topographic effect because this piece of cornea you can put more anterior than you can put an intact segment because cornea won't extrude like plastic material will, and you can use a much thicker segment if you use cornea than you can use for intacts. And so the flattening effect you get is much greater. So here is a pre and post Scheimpflug image, and you can just see how much the cornea is being pulled down into a much normal configuration. Here's a little video that shows CARES implantation, and it's very, very similar to Intacs. We also use a manual method. We mark the cornea. We use the same diamond blade and use the same little hook for dissection, followed by this blunt corkscrew dissector. These are secondary incisions that we create to help us pull these CARES into position. I've stained them blue here and dehydrated them a bit just to make them a bit easier to push into the eye. So here I'm sort of feeding this CARES segment into the eye, and this is using a Y rod, which is Susan's idea to help push these segments into position. So here I am just sort of gently feeding them into the wound. And this little image shows there at the top that you can see these segments much better if you stain them with something. In Susan's original paper, she uses riboflavin, which is kind of this nice yellow color. And in my practice, we use this trypan blue, and it's just sort of a little alternative. But once you have the segment in, it's very easy just to sort of push along halfway. And once you have it basically halfway pushed into the eye through the primary incision, you can come around from the other side and pull it the rest of the way in. So here we go. We're pulling the segment in. Yeah. And then you can do a similar thing from the other side. And by using two segments, you really can flatten even very steep corneas. And I'm not sure you can see here in this picture, but you can see perhaps the temporal wound especially is gaping here. And so almost always we do end up suturing these wounds here. And the reason that we have to suture these wounds almost always is because the flattening effect that we get with CARES is so dramatic. I mean, the cornea is so much flatter immediately on the table that the wounds won't close unless you put a stitch in them. And so we have been so impressed, so pleased to be able to offer this to our patients. There's one other procedure that I want to tell you about before we sort of wrap this little brief talk up, and this is the brilliant invention of Susan's partner, Dr. Agrawal, Amar Agrawal, pinhole pupiloplasty. He had the incredible realization that even patients with very severe irregular astigmatism see much better in the clinic when you use the pinhole occluder. Now, there are pinhole aperture IOLs available some places in the world, but if the patient is already pseudophakic, that means you have to do an IOL exchange. If they're phakic, then that means you have to do cataract surgery on somebody who may not have a cataract. Not to mention these pinhole aperture IOLs aren't available in the States and many other places in the world. And where they are available, they're expensive. So he thought, well, why not just suture the iris into a little pinhole? So these are all of his pictures, but this is a procedure we've been doing quite a lot of for patients with irregular astigmatism or corneal ectasia, putting 2 or 3 stitches in the iris to cinch the pupil down into a central pinhole. This is a very easy procedure. It's a reversible procedure. These stitches can be cut in the clinic with the YAG laser. So it has this nice safety buffer that if there was ever any problem, it can be undone. It's also very nice to counsel the patients about it, because when describing the procedure to them, you just hand the pinhole occluder and say, do you like your vision like this? and they will tell you yes or no. And if the answer is yes, you can be quite confident that the patients will appreciate the vision that they get with pinhole pupiloplasty. So it improves vision in patients who are otherwise very difficult to manage in a very safe and predictable way. So this has been something we've been quite pleased to offer to our patients with keratoconus or post-RK ectasia who have few, if any, other options. So in conclusion, I will tell you that cross-linking is a very nice thing. It's changed the game for our mild to moderate keratoconics. The very best surgical things that we have for keratoconus were invented by Susan Jacobs and Amar Agrawal, and I'm just so pleased to have had them teach me directly how to copy them. And if I can help you copy them, please let me know. And thank you so much for your kind attention during this talk.
Wow, thank you, Jack. That was really an amazing talk. Very well covered. I think you covered all the aspects of keratoconus exactly as the title goes, right from diagnosis to management. I would probably just like to start by asking you one question, something that you said about progressive keratoconus, how it's really essential to cross-link these patients, and especially how you can have progression even with a gap of just 3 months, which was seen during the pandemic. What is your criteria for pediatric patients? Let's say you see a child who's got keratoconus for the first time. Would you cross-link the patient straight away?
We are constrained in the United States in that corneal cross-linking is not currently approved to be done in the operating room, which is strange. In many places in the world, it's done exclusively in the OR. But here in the States, it's done exclusively in the clinic. And so if you have a patient who's unable to participate in their care, if you have a child who's 5 or 6 years old, it can be very difficult to cross-link those patients in the clinic because they just can't cooperate. You more or less have to do them under general anesthesia. And there are only a few places in the country, in the United States, in which cross-linking under general anesthesia can be done. So there is a huge need for that. I would say most truly pediatric patients with progressive keratoconus are underserved and undertreated in the United States. When I see these patients, I myself have to refer them to other places in the United States. And just this week, actually, I had to send a 7-year-old child with mental disability hundreds of miles away to a research center where they could be cross-linked in the operating room. So I think that probably we should be very aggressive with it. But because it's so logistically difficult to accomplish, it's being underdone.
Sujatha ma'am, would you like to add something to that about your practice here in India?
Yeah, pediatric keratoconus, I'm definitely more vigilant, and I would jump in earlier than adult keratoconus. I wouldn't do it in the first sitting. First, as soon as I see them, that will not be my approach. Unless the patient is already crossed beyond a certain extent, when the cornea is really getting thinned out, then I may be offering it as a first resort. But I would like to give the parents time to digest it. So ask them to come back after 6 weeks to see how they are progressing. If the patient has a history of eye rubbing or VKC, so probably educate them. And definitely, I would do it much earlier than I would do in adults. Yes, I would.
Lionel?
I have some additions, since it is pediatric keratoconus. As far as we know from the literature, pediatric keratoconus behaves very aggressively when compared to the adolescent type. So what we learn is we need to cross-link at the earliest, but the minimum age when to cross-link, I tried to find from the literature, but I don't find one, the minimum age. But as far as I know is we need to cross-link and be aggressive at the early stage, because the risk of progression is 88%. And the need for keratoplasty and the involvement of the other eye is 33% in pediatric keratoconus. And also another factor which we need to understand is cross-linking in pediatric cases less than 10 years. The stability, as far as we have this 10-year study, we could find articles, and after 4 or 5 years, there can be again the efficacy can go down. So should we re-cross-link? How are we going to manage? All these are a challenge. unlike the adolescent component and the early 20s, the second decades, third decades, pediatric keratoconus behave very aggressive.
Yeah, I think
most of the studies which have been published on pediatric keratoconus, they say whether they do transepithelial or epithelium off, it doesn't work beyond 2 to 3 years. Probably because they have associated VKC or the history of eye rubbing is continuing. So that may be one of the reasons. But majority of the studies say that most often the cross-linking has to be repeated.
So the youngest one actually is...
sorry, ma'am. If I'm allowed,
please.
That's again because of the imbalance between the anabolic and the catabolic processes of the keratolysis, and that is stabilized after probably the second decade. So when we do and when we find the pediatric keratoconus less than 10 years, the imbalance still follows. So that is one probable reason that there is the cross-linking efficacy goes down over time.
Yeah, the youngest I've done actually is around 7 years, and it was a very overt keratoconus. And I actually do not wait to see it progress because it is not congenital. So obviously it's progressed over a period of time from an earlier stage. So I believe that it's better to just cross-link. I mean, at least counsel the patients for cross-linking and go ahead with it after having treated the VKC and all that.
As Jack said, the trichome is Downs.
Yeah,
the incidence is quite high, more than 50% maybe.
Yeah,
so we may have to do
I think that's actually an interesting point, Lionel, that you made, and I don't know whether Jack, you also have any experience with this, but I found CARES actually to be very useful in both pediatric patients as well as in advanced cases of Downs and pediatric cases, because these are the patients where DALC is really more difficult because your follow-up is difficult with the sutures. The sutures may start loosening. You have much more problems in these patients with DALC as opposed to patients who are cooperative adult patients. So these are some subsets of patients where I have actually been able to apply very well CARES and cross-linking together.
Susan, I have a question for you as well as for Dr. Jack. He had mentioned in his talk that when he's doing CARES, he puts the rings closer than what you would do in an intax. So how do you do that?
Jack, would you like to take that question?
I'm sorry, say that one more time.
I think, ma'am, you mean more superficial. What he meant was superficial.
No, I think it is the diameter of the channels.
Yeah, channels. He says it comes closer than when you do an intax. Am I right, Dr. Pankaj?
Well, what I meant to say is that the position of the care segment in the cornea, you can put it more superficial, not necessarily more towards the pupil, but more superficially in the cornea. And a more superficial placement causes a greater anterior flattening of the corneal surface.
Okay. I thought
what I'd also like to say is that, ma'am, you can actually go closer also. In fact, with CARES has an advantage over synthetic segments in that you don't have as much of glare and halos with CARES as the intacs can do. So you can actually take smaller optic zones as well.
Yeah. For all of my intacs patients, I have to counsel them. I say you will see glare and halos when you're driving. You will get reflections from the dashboard of your car. When you're watching movies in a dark room, you will see glare off of your intact segment. And I don't ever even have that conversation with my CARES patients. I just tell them this will improve your vision.
So what would be your diameter? What would you plan for having allergenic implants?
For allergenic implants, the segment diameter can be customized, and I think Susan, the inventor, will tell you much more about this than me. The channel diameter, I used a fixed diameter, which is just the diameter of the manual intacs dissection blade. I'm actually not sure off the top of my head, maybe 11.6, something like that. I'm not exactly sure how long the channel is, but it's a fixed diameter channel for all of my cases. The segments come in basically two standard sizes, which is a function of the size of the trephine. There is a small diameter trephine and a large diameter trephine. Somewhat counterintuitively for me, the small diameter trephine produces the thicker segment. And the thicker the segment, the more flattening you get. So what I use for all of my cases, because for cares, usually my patients are more advanced, they have more advanced keratoconus, is I use the smaller diameter trephine, and I don't further thin the segments. Now you can, if you want to use a knife, you can make the segments a bit thinner manually after you trephinate them, and that makes them very easy to insert, but it can limit how much flattening you get. So I use the smaller trephine. I don't trim the segments, but I do dehydrate them a bit, which shrinks them and lets me implant them in the cornea more easily. So if you use a large segment, and you can get it into the cornea, you can get dramatic flattening. The most flattening I've ever achieved with cares is I've had one patient who flattened 35 diopters and with very, very advanced cone. And you just have to see that one time. You know, it's kind of like your very first DMAC you ever see, you think, oh my God, yes, this works. With your very first cares patients, you just think, this works. Oh my God.
Amazing.
That's so wonderful. 35 diopters.
About the diameter, the 6.5 is, I think, what you're referring to, Jack, the smaller diameter one. The 6.5 has the outer diameter as 8, so you have an effective thickness of 0.75. The larger diameter, we designed it as just a 1 millimeter gap, so that comes to an effective width of 0.5 millimeters. So that's the reason the smaller diameter is actually giving you thicker segments. But I agree with you, Jack, and I also want to say at this point that Jack has been really innovative with this. He's made he's published already a lot of papers on cares. He's done the trypan blue staining, which really helps you to see it better, and he's also done the dehydrated cares. And also he's just got a paper out in JCRS, if I'm right, where you have manual dissection technique. I think Jack is the first person in the world to have used manual dissection for cares. But now there are, I'm also happy to say that there are a lot of people doing around the world now in Canada, Turkey, many countries now who've adopted cares as part of the treatment, Australia, and so on and so forth. I wanted to ask you, Jack, how many cases have you done till now? I know it's a huge number, but off the top of your head, what
40 maybe, something like that.
I think yours must be the largest series next to us. So that's a humongous number of cases. I remember at one time before the insurance problem came up, you were doing so many a week, and then
we were doing 3 a week. Yeah, and we had a year because of COVID and because there were insurance problems. But this is. I mean, when you first start doing it, you think that this is, if you've done Intax before, you think this is just like Intax. The learning curve is so low, it's so easy, but it's so much better. And so it's something that once you start doing, you do enthusiastically. And so the only reason why we haven't done, instead of 40, why we haven't done 200 is just because in the United States, there's a little bit of a difficulty getting them insurance approved. So consequently, now we're having to charge the patients for it. So it's a refractive procedure that we charge patients for, just like you would charge them for LASIK or any other out-of-pocket. But, the patients are happy, in our experience, to pay for it because they just see so much benefit. And we're happy to offer it to them because we see so much benefit.
What is your indication for going in for cares? I mean, as opposed to the other modalities of treatment? What will be your indication? What is the indication that you would say, like the optic astigmatism, or what is your criteria for taking up the patient for cares?
Maybe an additional question, Jack. What is the indication given the situation, given the procedure of cares in your hand? What is the indication for DALK in your practice now?
Well, they're very similar answers. And I will tell you that even though I see probably 20 keratoconic patients a day in an average day, it's a huge part of our practice. I haven't done a PK for keratoconus in more than a year. And in the past 1 year, I've done one DALK for keratoconus, one. And it's not because I think the surgery is bad. I had Garrett teach me Melis Manuel Doubt. I learned from him in Holland, and I think that it's a great surgery, and the big bubble is a great surgery. But for so many patients, you just like to try to avoid some big incisional operation if you can. And scleral contact lenses are so much better than they used to be. You can have a patient with a Kmax of 80, and they can wear a scleral lens. And if you can wear a scleral lens with a Kmax of 80, then you'd hate to do a PK on that person. And now, especially when you can take someone with a Kmax of 80 and flatten them down to 65 with CARES. So what I like to do is if the patient is older, if they're pseudophakic and older, then I think about pinhole pupiloplasty for them. Okay, that's really the procedure I'd like for advanced keratoconus in an older person, pinhole pupiloplasty. In a younger person with keratoconus who wants to see better, my number one procedure is CARES. And if CARES is not affordable, then maybe Intax or so, because most people's insurance will pay for Intax. And Intax is a worse operation, but it can be cheaper for some of my patients. But if you want to see better, the surgery I recommend is CARES. So it's a very simple algorithm.
Yeah, but what would be your indication? Say, for example, the patient has a spectacle cylinder of 3.5 diopters where he's comfortable wearing spectacles. Would you still suggest CARES, or it just goes beyond a certain point you would be suggesting CARES? Do you think that at every stage in keratoconus, it really plays a role? That's exactly what I'm asking.
Well, I think it does play a role. I probably don't have a sophisticated enough nomogram to answer you precisely. I have offered CARES to patients with best spectacle corrected vision as good as 20/25. If they have an inferior cone and you think, well, I can improve this, then I've done it on patients who are 20/25. I've also done it on patients who are 2400 or counting fingers. And I think that probably if you are really smart and good, you would say you would be customizing the thickness of the segment and the location, how paracentrally you place the segment. I really am a follower. I'm not a leader. And so I'm going to wait till Susan publishes the paper to tell me what to do, and then I'm going to start doing that. But so far we offer it for patients mild, moderate, and advanced keratoconus who want to improve their vision.
And after that, you do the cross-linking, is it? We've
done it before and we've done it after. We don't do it at the same time, but again, that's basically insurance-driven. But before and after, we've done both.
What about you, Susan? What's your recommendation for doing cross-linking?
We do simultaneously, ma'am, because for us, it's exactly the opposite of what Jack said. It's more convenient to the patient to actually just get both surgeries over at the same time. And insurance, as you know, many of the insurances do cover cross-linking. So at least that part of it is taken care of by the insurance scheme, and CARES is generally paid out of pocket. There are a very few insurances which have also covered CARES, but they're extremely limited in number. But most patients who are reasonably affordable do understand the benefits that this procedure offers them as compared to, the just plain cross-linking. Because with just cross-linking, you don't get much improvement in visual acuity as such. And it remains kind of the same, but it's stable. So this really gives you that improved visual acuity. I also, like Jack said, I use it for every case from mild to moderate, advanced keratoconus, depending on also topography. So like Jack said, if you have a mild case, the patient may read 6'9" or 6'6", but he may not be very happy with the quality of vision because of the coma, if it's a decentered cone. So a single CARES segment inferiorly just below the cone really just works dramatic wonders to get rid of that coma. It flattens out that steep area and really gives a lot of visual improvement to the patient. So I think that's a very, very good indication. I've done that for very mild cases also. In fact, I've had patients with asymmetric keratoconus who we do the first eye for, and they're so happy with the results that they actually want CARES for the second eye also. And then
thinnest cornea you will do CARES. Thinnest cornea. See, for Intax, you have a cutoff. You have 400.
I have, Jack, I'll let you also answer this question. I'll just take it very quickly first, though. I have done it for 280, and that was a patient who had a thinner area where that had gone down to 280, and in that small part alone, I did not remove the epithelium. CARES you can do in any thickness of cornea. It doesn't matter. If you're placing a DALC, if you're placing cornea over just pre-descemet's membrane, the cornea still stays there completely healthy. So CARES is not going to cause a problem as such. It's the cross-linking that might cause a problem. So CARES I'm comfortable doing with any thickness of cornea, but the cross-linking is what you have to see. And 280 I did just because it was a small area and I could leave the epithelium there and the rest of the area was thick enough. If it's extremely thin throughout, let's say 230 and things like that, I would rather go for a dial because those patients may not have the strength to actually stop progressing. That's basically my, but in again, as I said, in Downs and in pediatric patients, I really make a push for going for CARES first instead of DAL because they are the patients who will have maximum problems post-DAL because they're not available for follow-up. Your follow-up is never going to be perfect for them and so many issues with that. Jack, would you like to add something to that?
I've also done CARES in a patient with 280, and those are the best patients because their corneas are so pliable, they're so floppy, they flatten dramatically when you put the CARES segment in. They have the best results the thinner they are. And I will tell you that we do cross-linking now on any thickness. I mean, there's no cornea that I think is too thin to cross-link. And there are two reasons why I think that. So first, we've cross-linked 1,000 eyes, and we've never had an endothelial decompensation. And we've cross-linked some very thin corneas. And so I think that the risk of that is probably very low. And I think that for me, if it were my eye, I'd rather have cross-linking and then a DMEC if needed, than a PK. If you can get away with a DMEC instead of a PK, I think it's better. But the other thing is that we've just been so happy to use this contact lens assisted cross-linking technique, not only because it thickens the cornea, but one thing I've noticed is that if you have a very, very steep cornea, you have a cornea that's 70 or 80 diopter steep, even if you have the requisite thickness, when you focus the crosshairs of the cross-linking laser on the tip of the cornea, they don't focus. They don't come to a point because the cornea is so optically abnormal. But if you put the contact lens over the cornea, it does allow you to focus the energy of the laser. So I think not only is the contact safer, but I really think it gives you better treatment for these advanced cones. So we've been so comfortable doing that. I've never even thought about, I have to confess, Garrett invented Bowman layer transplantation originally for patients who are too thin and steep to cross-link. I really don't think that category of patients exists anymore. I think you can basically cross-link anyone.
Jack,
also,
yes.
just one thing, Jack has actually gone far beyond me in CARES because he's even done post-classic ectasia and I haven't yet, but Jack is really taking all extra indications than even I have. So hats off, Jack.
Jack, I have a question. I'll reframe Dr. Sujatha ma'am's question for you. If it's 280 or 300 cornea, it's understandable to have having an allogenic segment inside. What is your approach if the cornea is 430, 450? Will you still go ahead with significant inferior superior asymmetry? Will you still go ahead with CARES, or do you think of doing a topo-guided PRK and cross-linking?
I am a scaredy cat. I'm worried about doing PRK or some ablative procedure to a cornea that already is unstable. And I would feel really bad if you would have a patient that you think has mild keratoconus, you treat them with PRK and cross-linking, they come back 2 years later or so and they're worse, they're progressed. Now, maybe they would have progressed anyway, even if you had not done PRK on them, but you would feel really guilty and bad if you had done something to thin and weaken their cornea. So that's not something that we do. Maybe I should be doing it. Maybe in 5 years I will be doing it. There are some people that I very much respect who do that, but I'm currently too cowardly to do it.
I think I also agree with that. Yes, ma'am.
So I just want to, Dr. Parker said it uses a manual method. What is your take on it? Do you use a femtosecond laser assisted CARES, or you also do it manually?
You're asking me, ma'am?
Yes, yeah.
Oh, unfortunately, it's a reverse situation. I don't have the manual dissector and I wish I had it because I have many unaffordable patients who cannot afford the procedure. So if I had a manual, I definitely would go for it. But since we have only the femtosecond, I'm currently doing only the femtosecond laser. But if I had a manual, I think I would go to Jack and learn how to do it and then use it.
The question is, over a period of time, have you seen any patients drift again coming back, the coning starts again. Have you seen in any of your patients? Because
Fortunately, no, ma'am. I have not had to. Actually, I have had a very good experience with both CSC XL and CARES in that the progression really stops. When you combine them, the progression really stops. Fortunately, touch wood, fingers crossed, everything. I haven't had a patient where I've had to do, where I've had to go in and convert to a DALC. But that option, the advantage is the option is always there. If the patient has worsened out for any reason, you've not lost anything by having done a CARES or a cross-link. You can still do a DALC. But fortunately, I've never had to do it. That situation has not yet come to me.
The other question I have is, I'm sorry, can I go ahead?
Yeah, please.
Yeah, please.
I just been in tags, we sometimes see vascularization and the deposits, and some of these patients have a chronic blood vessel coming into the. Do you see any of those things in CARES?
No, I haven't. With intacs, I agree that deposits are very, very common, and the vessels are, I'm not sure, maybe I overlooked them. I think probably less common. With CARES, I will tell you one mistake that I made when I started that I'm confronted with when I see these patients back post-operatively. When I started doing the surgery, I thought it was much, much easier to dehydrate the segments. If you dehydrate them, you thin them, and it makes it easier to push them into these corneal channels. When you dehydrate them, you need to put them on top of a Maricel sponge, not a Wexel sponge. For the same reason you don't use Wexels with LASIK, you get little bits of Wexel sponge in the interface. So if you look at my first 10 CARES, they all have sponge in the cornea, which is very embarrassing. Fortunately, it doesn't seem to impact the patient's eye, but makes you feel like a real idiot to leave pieces of sponge inside the cornea. So I don't recommend you make the same mistake I did.
I think, and Jack, you also wrote about this in OSN, right? I remember Yeah. And ma'am, about the vascularization, I haven't seen any patient with vascularization except one. This was a single patient where I had it. And the reason was that was a very, very long ago patient, probably in 2016. I started this in 2015, so a year into it. And that was probably because, when I got this idea of putting in allogenic tissue, I never expected that I would be able to put it in one side and take it all the way around to the other side. So what I thought in my mind was going to be very difficult to push it in all the way. So my idea was to push it in half on either side of the incision. And that's how I started with. So the incision would actually straddle the segment. And all the patients still, touch wood, did fine, except for one patient where my channel got decentered and the incision cut came very close to the limbus. And that is a single patient where I had blood vessels growing into the channel. And it was simple for me. I just removed the segment and it comes out beautifully, actually, without any problem. And I just put a stitch on it, and that basically took care of the problem.
Do you also make an opposite side incision, just like Dr. Jack?
I do, and I think Jack also does, because we use it for taking it from the reverse Sinski.
The 180 degree.
Yeah. But one thing I've recently learned is if you really dehydrate the segments, if you let them sit out for 30 minutes or so on top of a sponge under air, they will become really stiff, and you can push them in just like you can push in an intact segment. And there's a video that I think I shared with you, Susan, of doing that last week or so, but you can push the segment in completely from one incision if you let it get stiff enough.
Yeah, actually, yes, that's true. And also, with the femtosecond, I also make a little larger channel, so you can actually just kind of push it over the cornea, just keep pushing, and it just slides all the way around. So especially if you've also done riboflavin, it becomes even more easy, I feel, because riboflavin is a little slippery and it helps it move along.
Maybe 1,100 microns.
By the way, I've also used viscoelastic ones instead of riboflavin a couple of times, actually, to help it slide across. Just wanted to see if it makes it easier.
It works. Viscoelastic works.
Yeah.
Interesting.
Just makes it a bit slippery.
Yeah.
So on the table, you do the cross-linking. As soon as you do CARES, you do the cross-linking, Susan?
Also, yes.
And you remove the epithelium.
Epi off. After you remove the epithelium, you just need to kind of, make sure the segment is spread out again, and then hit with it. Lionel, you were saying something?
I was just asking if the channel is similar to that of Intacs, 1,000 microns, 1,100?
You mean the width?
The width of the channel.
The width of the channel, Jack takes us fixed width with the manual one.
Exactly the same.
Exactly the same for all of them. And I use channels widths depending on the segment thickness that I'm taking. For the thinner segment, I take a slightly thinner width, and for the thicker segment, I take a thicker width.
Interesting.
But I really, these procedures are not like classic. This is what I always say. They're not like, you don't have a completely fixed formula there. So these are more, they're more like art. So you kind of put this and you expect a flattening there. You know where you're going to, topography is going to flatten out. But you may not get the exact same result in two patients because it also depends on the biomechanics of the cornea.
Yeah. And it makes sense. The central cornea, central 3 to 5 millimeter, if the central 5 millimeter is free of any irregularities, then it makes sense.
Also, as you push in, you know that the cornea is so pliable in some of these patients, the results will be excellent. Even in intacts when you're doing, some of them, they're given so fast, so much. So, the results will be very
Actually, ma'am, even in mild keratoconus, especially for the decentered cones, they do very well, even if the cornea is not that pliable. Because what it also does is adds tissue. So it's like the Baraka's law. When it adds tissue, it flattens it over there. So that automatically gets rid of a lot of the cone.
Something similar to what Sri Ganesh published, no?
The lenticule.
He used a smile lenticule.
He used a smile lenticule with a central hole cut in between. So that the thickness is not as much as this. Yeah. This is like a solid.
That really doesn't produce sufficient flattening.
Yeah, when I started reading about KERS initially, I thought, well, this just doesn't make any sense. It couldn't possibly work because the intact segment is so stiff. It's a piece of glass or plastic, and the KERS segment is just soft, pliable cornea. How could it possibly flatten the cornea even close to as much? And Susan sat down with me personally and showed me her videos and showed me her PowerPoints and taught me how to do the procedure. And when you see how much better the procedure works, you realize everything you think you understand is wrong. You don't know anything. Your whole understanding of the disease is wrong. And it's just so enjoyable to be wrong in that way, to realize something totally new, not to have a slightly better technique or slightly better way of doing something, but you just feel like you're seeing something clearly for the first time almost.
I completely agree, because that was also my thoughts when I first did it, because I also was not sure how it would work. In fact, as I said, even the technique evolved with time. I started off by sliding it on both sides, and I realized that, you could use an intact and pull it around. And then I made a designed an instrument, and then it just kept evolving along with time.
I think I owe Susan also, she's my teacher in intacts.
Many years ago.
Such an easy technique. And I can do intacts in 3 minutes. It's so fast. Unbeatable, Susan. I think.
Yeah, and KERS is the same way now. It really is.
I live 5 kilometers away from Susan. I just live 5 kilometers away. I'm still not started doing KERS.
Yeah, you have to soon now, ma'am. I think we are coming to the end of
one comment, Jack. I really loved your hypothesis. Eye makeup in young women, and they don't want to disturb. That reduces eye rubbing. I loved it.
Okay, is that, sorry, just before closing, there are 3 questions, audience questions. One is, can we go for ICL post cross-linking patients, and if so, when? Lionel, would you like to take this one?
Yes, ma'am. Once if the cross-linking efficacy is proven, maybe a year or later, we had a series of cases where nearly 35 cases we cross-linked, and once that is stabilized, we did a bioptic surgery, correcting the irregularity in the corneal plane without disturbing the lens plane. So that improved vision and stabilized the vision, as well as the higher order aberrations, and also contrast sensitivity function improved. So we had that collection of case series. Maybe a year or more should be good for a bioptic surgery.
May I ask you a question about that, Lionel? Is that okay?
Mm-hmm.
How do you size the phakic lens? How do you determine what the size should be? I've heard that there is some problem with using the white-to-white measurement in keratoconic eyes for phakic IOLs. Do you have any advice?
We not alone use white-to-white, but also we use other variables to predict the post-operative vault, what you mean. The angle-to-angle distance measured by OCT, the angle depth, the angle width, and we did a multivariate analysis in our series of nearly 96 cases of phakic IOL, and we found, in addition to white to white, the angle to angle, primarily it is the transverse diameter of the eye and the depth, and also the phakic IOL diameter, 12.6 or 13.1. So all these determine the vault size. So that is what we finally found. It is not alone white to white. There are various other parameters also.
I have to say this one thing about Lionel is that he is so interested in research. He does these absolutely fantastic studies, and he's also into so many clinical trials. It's really something that I always envy him a lot for. That's something, Lionel. One more question. Two more questions, actually. There's this one quick question, which I think I'll just quickly answer. Do you cross-linking those patients going for cares? If so, which protocol? We almost already talked about it. If thin corneas, you can go in for CACXL. There are also other thin cornea protocols. Whatever you're doing for cross-linking, now the same protocol. I don't prefer epi-on. I think maybe Sujatha ma'am is also the same. And Jack, do you do epi-on, or is it generally epi-off?
Epi-off.
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 Also epi-off. So if you'll see many keratoconus, people who deal with keratoconus regularly prefer epi-off somehow, because epi-on doesn't seem to have the same amount of effect. So generally epi-off, but epi-on is a personal choice, especially with the newer techniques. The last question is, what is the tone of iris upon reversal of PPP? This is one question. Lionel, do you want to take this question?
What is the question now?
What is the tone of the iris upon reversal of pinhole pupiloplasty?
Tone of iris.
Yeah. So if you'd rather not, maybe I'll take it.
Yes, please.
So the PPP is generally basically, kind of putting those sutures there and doing a suture lysis if you want to do it later on. And I personally haven't had any experience of having to open up the iris. I think Dr. Soundari, who's one of our very senior consultants in our hospital, has done it for a couple of cases. And what she told me when she did it is that she's able to open up the iris, to the desired size. So I think that does work well, and you can go ahead and reverse it if you feel that you've made it too small for any reason.
So you mean to say it's a reversible thing?
It's a reversible thing, exactly. So if you...
The question is whether it was floppy, whether it becomes floppy. But that actually really does not matter, because what you're going to do is a suture paralysis using the YAG laser. Am I right, Susan? They use the YAG laser.
A YAG laser is used to cut either the suture or even maybe make a sphincterotomy if you want to.
So it really doesn't matter whether
it wouldn't matter, right? I think we had a very exhaustive session, and it's 7:02, so we should wind up. Now, I'd like to thank everybody, all the participants, Jack, especially you, for taking time out from your first day as a new dad. And really wish you a very, very happy time with your lovely wife and your new baby daughter. Thank you so much for having come to the meeting. Sujatha ma'am and Lionel, thank you so much for taking out time. It's really fantastic to have you both here. Moses, Rakesh, Kala, thanks so much for being part of this. Thanks a lot for having participated. Thank you so much.
Thank you. Thank you.
Thank you. Honored to be a part of the panel. Great to meet everybody.
And enjoy your parenthood.
Yeah.
Jack.
Thank you.
Congratulations and best wishes to you and your wife.
Yes. And Iris too. Iris
and Iris.
Iris is an international name now. This is our first international exposure, Jack. Bye-bye.
Bye-bye.